This is Anatomy Procedures, Chapter 15 of the Digestive System. Had to break this. There's a lot of content in Chapter 15, much like the skull chapter, so I decided to break it into 2 recordings. It is one continuous PowerPoint. It's 108 slides long. So the partition point that I chose was I'm going to cover like introductory material about the alimentary canal, and then go into the anatomy of the esophagus, anatomy of the stomach, and then we're going to cover the procedures for those two, the esophagram procedure, the stomach procedure, the upper GI. And then that's where this part 1 is going to leave off. It's going to stop after the upper GI. Part 2 is going to pick up with the small intestine, the small bowel follow through, and then finish with the barium enema. So that was the cleanest way to break it up. That's why this one goes just a little bit longer, slide 1 to slide 62. The other one just a hair shorter, but this is about halfway through the content of the chapter. So here we go. All right, so we're going to talk about the anatomy of the GI tract. It should be review for you because you had it in structure and function class. What's new to you might be the preparations for GI procedures and how does the contrast material barium sulfate behave chemically, and how does that impact the way we perform the exams, and how barium sulfate is going to behave inside the body after the patient swallows it. So those are important considerations that we have to be aware of as we're giving barium sulfate to people. So, and we'll also talk about iodine in solution, which is the other aqueous iodine solution, which is the alternate contrast. And we'll talk about when it's appropriate to switch to an aqueous iodine solution rather than barium sulfate. There's a couple of contraindications for barium sulfate, and we'll cover those as we're talking about barium sulfate in those slides. Okay. I think I did integrate image critique into a lot of these just because you don't see post-procedure overheads anymore, so I include them in the recorded lecture. If we can find some on PACS, I've not had success with those because, again, no one takes those anymore. So in an effort to kind of bolster the image critique part, I think I've included it here in the lesson, the initial lesson, whereas I usually separate that content from the procedures lecture and all the other lesson plans. So type, dosage, route of administration, yeah, we'll go into what types of contrast you'll have to prepare for each procedure and how do you get the contrast into the patient's body. All right, so let's start with just the entire digestive tract called the alimentary canal. It's basically a tube. Musculomembranous means it's got mucous membranes on the inside, smooth muscle on the outer layers, and it runs from your mouth to your backside. Okay, yes. Mouth, pharynx, esophagus, stomach, small intestine, and large intestine. Those are the major components of the alimentary canal. The GI system also has accessory organs like the liver, the pancreas, salivary glands, so on and so forth. So alimentary canal really just means the pathway for food and then waste products at the terminal end of the digestive tract, whereas the GI system includes those accessory organs like the liver and the pancreas and the salivary glands. Okay. So yeah, this is a picture of it. We have the tongue is useful in moving food around your mouth. The tongue is a muscle. It's a voluntary muscle. It houses your taste buds, so it's got a sensory component, um, which in combination with your sense of smell kind of guards against poisons. Things that are bitter or taste bad oftentimes are also poisonous, and so that is why the taste buds exist. Taste buds also exist for things like chocolate and cheesecake and sugar in general. Um, Around the tongue and around the oral cavity, there are three major salivary glands: the parotid gland, the submandibular, and the sublingual gland. Okay. As you transition out of the oral cavity, the food bolus extends into the pharynx, and the pharynx job is to start the swallow response. Um, so sort food boluses from the airway. And so that's an important part of the pharynx is closing off. I'm going to stop while they're doing that overhead announcement. Hang on. All right, so yeah, sorting the food boluses from the airway. The epiglottis is part of the swallow reflex. The epiglottis is supposed to snap shut over the opening to the trachea, and then the food bolus is supposed to channel down the esophagus. The esophagus has a peristaltic motion. The swallow reflex is separate from, well, they're kind of related. The mass peristaltic motion of the esophagus is kicked off by the swallow reflex. And so you get a relaxation of the smooth muscle in the esophagus in front of the food bolus, and then a contraction of the smooth muscle in back of the food bolus to continue the swallow motion all the way down to the stomach. And so the food bolus doesn't, or is not supposed to, hang out in the esophagus for a very long time. It's supposed to immediately transition to the stomach. Stomach is a holding tank. It's not where digestion begins. The salivary glands actually start breaking down the food chemically, and then of course your teeth break down the food mechanically. Okay, but then the stomach adds hydrochloric acid to the mix and starts mixing, and in addition to being a holding tank, it does have smooth muscle that can mix and churn the contents, the inner contents, and thoroughly distribute the acids, and the acids start attacking molecular bonds and starting to break apart macromolecules into component nutrients. Okay, it's not complete at the end of the stomach. That process actually completes in the small bowel. Okay, a little later on down the line, we'll get the parts of the stomach in greater detail. But for now, let's just continue on. We go into the duodenum from the stomach, and that's where we get the addition of the bile from the biliary system, plus also the pancreatic juices from the pancreas, which serve to further break down different components of food. Biliary system, the bile secretion is meant to emulsify fats, and then the pancreatic juices are meant to separate, break up fats and proteins in particular into component amino acids for absorption. Okay? So once they pass the duodenum, more mixing and churning, but also a spreading out of the bolus through the small intestine, and a rhythmic oscillation peristalsis that moves the boluses back and forth, and that's so that we give the digestive agents, the digestive enzymes, time to work and fully break apart macromolecules and promote absorption in the villi of the small bowel. Okay. Once it gets to the end of the small bowel, most of the nutritive value has been absorbed, barring any pathology. And then the bolus enters the large colon. Once the bolus enters the large colon, it's considered stool, not food bolus anymore. The nutrition has been harvested away from, so all that remains is waste product. Okay. The first portion, the receiving portion of the large colon, is called the cecum. Less mixing, more compacting of the waste, and then drawing off excess water. Those are the main components of the large intestine. If there is a bacterial or parasitic irritant, the large intestine can also draw water in order to clear its contents faster. The large intestine does not like to hold on to excess water, and it's one of the triggers for cramping and mass peristalsis is the addition of water to the large intestine, and we need to keep track of that during the barium enema, because that's exactly what we're doing, is we're effectively filling the large colon with water, and that physiological response is cramping and diarrhea. So, all right, moving on, further, a deeper dive into the anatomy of the mouth. It is called the oral cavity. Enclosed dental arches, those are your top and bottom rows of teeth. Receives saliva from the salivary glands, and the saliva does contain enzymes to start breaking down the food. Okay. And so there's the oral vestibule and the oral cavity. Those are the two components. The oral vestibule is the space between the teeth and the cheeks, but the oral cavity is in between your teeth. Where your tongue resides is the oral cavity. So yes, you can get food in between your teeth and your cheeks, but that's not the useful space. That is part of the space, but it's not the oral cavity proper. Okay. On the roof of your mouth, you have the hard and soft palates. So, and the distinction is I believe it's the vomer and the palatine bones. I'd have to review the skull anatomy. Form the hard palate, and then the soft palate is just soft tissue. There is no bony tissue underneath the soft palate. Okay. The floor of the oral cavity is formed by the tongue. Okay. Communicates with the pharynx posteriorly via the oropharynx. So the oral cavity transitions to the pharynx at the back of the teeth. Okay. So here we have a open mouth view of the mouth. Okay, so your hard palate is more anterior, but if you feel with your tongue, you can detect back by your molars the bony underlying tissue disappears. So the maxilla and the palatine bone. I was wrong about the vomer. I guess the vomer is the posterior perpendicular plate. My apologies. So maxilla and palatine bones form the hard palate, and the soft palate is posterior to that, behind the last molar. Okay, and it's just soft tissue. It's still mucous membrane. It's still membrane tissue, but it doesn't have bony support, basically. The uvula is a small pendulous process in the center of the inferior border of the soft palate. The uvula, I believe it has a function in kicking off the swallow function, because as you pass a bolus past it, you necessarily push the uvula out of the way, and so that might send a nerve signal to begin the swallow reflex. Okay. And then your tonsils are located between the anterior and posterior arches of the soft palate, tucked in on the sides, unless you had them removed. They do get rather big when you're little. Tonsils do eventually atrophy, okay? But they can cause swallow dysfunction. Okay? So the difference in this diagram here on this page is the tongue is raised, so we can see on the sublingual space. The apex of the tongue is anterior, that's the tip of the tongue. The base is posterior. The base is actually in the pharynx. The sublingual space is part of the oral cavity floor that lies free, anterior and lateral portions of the tongue. Okay, so there's a sublingual fold down there. There's a frenulum of the tongue. That's like the cord tissue that kind of anchors your tongue to the floor of your mouth. And then, of course, the sublingual space. And you will the sublingual fold also holds the terminal ends of the submandibular duct. Okay. The frenulum of the tongue, yeah, that's a tricky one. It is a vertical band on the inferior surface of the tongue. Restricts posterior movement of the anterior part of the tongue. So it's basically a safeguard so you don't swallow your own tongue in your sleep. Okay. Teeth. The teeth are there to chew food. That's pretty obvious. I don't even know why I had to include that as a bullet point. I guess being thorough. All right, so here is like a cutaway or an X-ray view illustration. Okay, and this is showing the location of the salivary glands and their ducts. Okay, so it looks like the sublingual and the submandibular duct, they share a single duct, whereas the parotid gland has its own duct. Okay, the submandibular gland is often one, when you get strep throat, you can also have swollen glands. And typically what they're palpating for is if there is edema and swelling in the submandibular gland. It can be palpated. You go right under the edge of the jaw on the left and right side, just anterior to the gonion, and that's the tissue of the submandibular gland. And if it's inflamed, it will be like a hard lump right there underneath your jaw. Okay. So those are pairs. There is a left and right version of each of those, the parotid, submandibular, and sublingual. Here's your Jeopardy question of the day. Yes, about 1 liter of saliva per day. That's a lot of saliva. Where does all that go? Okay. Saliva mixes with food during the chewing process. It softens the food and contributes digestive enzymes. It also adds to the moisture content of food, making it more malleable and easier to pass peristaltically. So yeah, here's a cutaway view of the throat. I think this is also this diagram was also in the thoracic viscera chapter for the soft tissue neck. Same diagram basically. So there's your tongue, there's your epiglottis. The hyoid bone is connected to the epiglottis, and it looks like it's a fulcrum point for the epiglottis. So as the tongue forms a bolus and pushes it backwards into your oral pharynx, that produces a certain contraction of the tongue muscle, which also stimulates the hyoid bone and its associated muscle and produces a secondary contraction that slams the lid shut on the larynx. Okay, so that's all supposed to be an automatic process, whereas a certain motion of the tongue will eventually cause the epiglottis to slam shut about a half a second later. But that process, it is a nervous system response. It's a reflex response, and it can be pathologically. Most common cause is CVA. A stroke will cause an altering to the swallow reflex or a delayed swallow reflex. Okay, so we do want the food to go into the esophagus, not into the trachea. Remember, your trachea is anterior to your esophagus. So if you are watching a swallow dysfunction exam or a swallowing series on an esophagram, any penetration anterior typically will result in the end of the case because it's not safe for the radiologist to proceed when they've just witnessed a barium aspiration. Small volumes of barium in the windpipe can be coughed out with most of the time negligible risk of aspiration pneumonia. But if the radiologist were to continue, then you have a large bolus of barium in the airway. You could cause an airway obstruction, and or the real risk, the high probability risk, is aspiration pneumonia. And so that's why the radiologists usually terminate the exam upon aspiration. Okay. Not that you should cheer for that. That means the patient's not able to swallow things without choking on them and sending them down their airway. That's not something you should celebrate. Okay? So our pharynx extends from the body of the sphenoid and the basilar portion of the occipital bone to about C6, C7, and then it becomes the esophagus. Okay, it's got a there's three portions: the nasal pharynx, the oral pharynx, and then the laryngeal pharynx. Remember, it's both part of the digestive system, but also the respiratory system. And so the nasal pharynx and laryngeal pharynx are respiratory system structures. The oral pharynx is the digestive system structure, and they have to cross each other. And so that's why the epiglottis has to be the way it is because it's a shared space with the airway. And so we got to shut off the airway temporarily while we swallow, or at least we're supposed to. Okay. So as the pharynx tapers, once it stops tapering and becomes just a cylinder, that's when we call it the esophagus. Okay, and the esophagus is just a small flexible tube. It typically collapses on itself when it is not holding a food bolus. So on CT slices, you won't see an open esophagus, but you will see an open trachea. The trachea is held open by banded cartilage, those cartilage rings. The esophagus doesn't have anything to hold it open, so it just naturally collapses on itself when it's not holding a food bolus. Okay. Esophagus does bend just slightly when it passes in close proximity to the aortic arch, and then it also bends anterior to posterior when it's passing by the left main stem bronchus. So it kind of does a little whoop-de-doo right there in the middle of the mediastinum. You can see the aortic arch impression typically on an esophagram, but you can't see the left main bronchus displacement unless you're in a lateral position. Okay. The esophagus passes through the diaphragm, and then as it passes, this diagram is actually flawed. As it passes through the diaphragm, continuous with the diaphragm is the cardiac sphincter, which is the banded muscle that can pinch it closed and keep the stomach contents from washing up. So our esophagus starts at about C6. This is through the diaphragm at T10. Joins the stomach at the esophagogastric junction, also called the cardiac antrum at T11. Okay, so the difference between the antrum and the sphincter, the cardiac antrum is the passageway at the distal esophagus. The sphincter is the banded muscle that opens and closes that passageway. All right. Ooh, font could have been bigger here. Sorry about that. All right, so transitioning into the next structure, that would be the stomach. And so we see the cardia region. That's where the food bolus has arrived. There's our cardiac antrum, which is the last portion of the esophagus. The cardiac notch is the little bend in the shape of the stomach in between the fundus and the esophagus. The fundus is the uppermost portion of the stomach that is above the cardia region or above the junction with the esophagus. Below the fundus is just called the body. The body is like the middle section of the stomach. The body is bound by, on the medial side, the lesser curvature, and on the lateral side, the greater curvature. Okay. The pyloric antrum and the pyloric portion. The pyloric portion contains the antrum, which is the tapering, to the pyloric canal. The pyloric canal is the portion of the pylorus that travels through the pyloric sphincter. Pyloric sphincter is the banded muscle, very much like the cardiac sphincter is the banded muscle, that opens and closes the bottom or the distal end of the stomach to enter the first section of the small intestine. Okay, so the stomach, as far as the food bolus is concerned, is after the cardiac sphincter, but before the pyloric sphincter. All right, a cutaway view shows us the inside lining of the stomach, and this is where we see the mucosal folds. Yeah, the rugae just add to the internal surface area of the stomach and allow for better mixing and breaking down of food boluses into tinier components so that in the next phase in the small bowel, those individual nutrients can be extracted. So the whole point is breaking down food into from macro structures into tinier morsels that are starting to become chemically altered. The addition of the acid helps with that and starts the digestive process. Right, so the entrance and the exit of the stomach are supposed to be controlled by the cardiac sphincter and the pyloric sphincter. Gastroesophageal reflux disease starts with issues at the cardiac sphincter and allowing the contents of the stomach to reflux into the esophagus, the distal esophagus. And that is the root cause for about 6 or 7 different esophageal pathologies. Okay. So the cardiac sphincter is supposed to control that opening. We do not want acid to get into the esophagus. It irritates the lining of the esophagus. Okay. And then at the distal end of the stomach, we want to control, because the stomach is a larger container than the small bowel is, we want to partition the meal, the food bolus that's arrived, and send it into the small bowel in tiny bits or bite-sized bits. So the pyloric sphincter opens and relaxes, allows a little bit of the stomach contents to enter the duodenum, and then closes back off again. And gradually piecemeal empties the stomach contents over the course of 45 minutes to an hour. Okay. The stomach position itself anatomically is affected by body habitus. You'll find that the hypersthenic habitus has the most horizontal stomach, and the asthenic and hyposthenic habitus have what's traditionally known as the J-shaped stomach, where it plunges into the pelvis. You can actually have the pylorus and the duodenal bulb at the level of the L5S1 or at the level of the sacrum in a asthenic or hyposthenic habitus. Yeah. The gastrointestinal transit, of course, is peristalsis. Peristalsis inside the stomach is slightly different because it's mixing and churning as well as advancing. 3 to 4 waves per minute occur in the filled stomach, but it does partition its release into the duodenum such that the stomach empties in about 2 to 3 hours, and that spreads the meal out through the small bowel because that's when the lead edge of the bolus reaches the ileocecal valve. The last of the meal is emptying out of the stomach. Okay. The food bolus needs to spread out through the small bowel for effective absorption. All right, so contrast media for these things, radiographic demonstration requires the use of contrast media. It's just a soft tissue. So the GI tract really doesn't show up all that well. You can't really see its features. You can't see the detail of the mucosal membrane without the use of contrast media. So what does contrast media do? It increases the attenuation of the X-ray beam in the area that it's introduced in. It does so because contrast media usually contains a molecule with a high atomic number, a high Z number. Barium sulfate does this by including barium, which has an atomic number of 56. And so it's a prolific absorber. Photoelectric effect is directly proportional to the cube of the Z number. So 56 cubed, that's a really big number, so that means the probability of photoelectric absorption for barium is extremely high as compared to like carbon or hydrogen, which is what the native soft tissue is mostly made of. So introducing barium sulfate into the GI tract promotes X-ray absorption within that barium sulfate, and then we can see effectively the GI tract because we can see the barium sulfate and where it is on the X-ray. Okay. We might switch out in some situations. Barium sulfate does have some contraindications, specific pathologies, so we might be also using water-soluble iodinated contrast media because with these specific pathologies, perforation being the number one, it's safer to use water-soluble iodine than it is barium in the case of perforation. Solutions move through the GI tract quicker than barium sulfate because they are hydrophilic. They draw water to them as they travel through, but that also means that they self-dilute. And so the ability of iodine, while iodine does have an atomic number of 53, because it's hydrophilic and draws more water to it, it self-dilutes and its concentration drops over time. And you go from a bright white to basically a gray after a prolonged period of time. And so typically, like a small bowel follow-through done with iodine, you can definitely see a difference between iodine contrast and barium sulfate going through the small bowel. But for an esophagram and a upper GI stomach, there's really no difference. It's only if the iodine is hanging out for a while that it starts to self-dilute and draw water to it. It does move through faster. Some techs spike the barium sulfate for a small bowel follow-through with a shot of iodine, like a 1 ounce of the gastrografin, to promote that motility and push the barium through faster. Okay. The iodinated solutions do not have the additive adhesives like we can put into the barium sulfate mixtures, and so clinging to the walls, the inside walls of the small bowel, iodine doesn't do that as well as barium does. Okay, but iodine is an appropriate alternative if barium sulfate is contraindicated. So we administer contrast media orally. Okay. Iodinated medium, it will outline the esophagus but not adhere to the mucosa. A satisfactory examination of the stomach and the duodenum. So iodine can be substituted for the esophagram and the upper GI with very minimal loss of diagnostic quality. It's when you get to a small bowel follow through that there's a significant loss in diagnostic quality. Okay. Oh, look, font too small. Sorry about that. So as the iodine bolus is going through the small bowel and possibly large bowel, it's drawing water to it and it self-dilutes. And so the bright white becomes a off-white, then a dirty white, and then a medium gray, and then, then just no difference between that and the mesentery. So it basically loses its ability to provide that contrast over time. You can do a barium enema with an iodine contrast because it does move through so fast if the patient cannot introduce the conventional contrast retrograde, so to speak, via an enema. All right, if there is aspiration or perforation of the bowel, aspiration into the respiratory system, penetration of the larynx, or there is a known perforation somewhere in the bowel, either large or small bowel, then you do want to use iodine contrast because it's less risky. Aspirated iodine contrast reabsorbs. It can be suctioned via tracheal intubation. If it penetrates into the peritoneal cavity, it can be reabsorbed and excreted by the kidneys, and it usually doesn't create any kind of additional septic risk in cases of a bowel perforation. All right, so our barium sulfate, inert. Inert means that it does not react with the body. It's not a physiological agent. It is not a nutritive agent, partially because it's got low solubility. It doesn't even dissolve into water really well. So because it doesn't dissolve and break into its component ions very well, that's why it's got low absorption. That's why it's effectively defined as inert. Now, barium sulfate is slightly hydrophilic, but not as hydrophilic as iodine is. And we're going to use barium sulfate. It is the preferred contrast agent for the GI system, except for history or suspicion of perforation. And then we switch to the iodine. The radiologist should be making that decision for us, but an S-bar does not hurt. So give them the background. If you have a concern that there might be a perforation or the patient might be at a big aspiration risk, you should advise the radiologist and reveal that information before the exam begins. The radiologist may recommend preparing with gastrografin rather than barium sulfate mixtures. Okay. And I say mixtures instead of solutions because that's the correct terminology. Barium sulfate is a suspension. It has fine particulate matter that are suspended in water with agitation, but they are not dissolved into the water. Okay? Over time, these suspended fine particles clump together in a process known as flocculation. Okay? After they clump together significantly and they grow in mass, they start to settle out of suspension. Okay? So barium sulfate, therefore, must be agitated or shaken vigorously as you mix it up, and then you use it immediately after its agitation and mixing. Okay? If you leave it sit on the counter all day, it will separate and start to fall out of suspension. Okay? And so a technologist needs to know that. Because then it won't. I mean, we need suspended barium to be a proper contrast agent. So your patient preparation, all right. So before we even feed them the barium or the iodine, depending upon what exam they receive, they will go through various stages of bowel preparation. Now, it might be as simple as don't eat anything after midnight. That's usually for an esophagram, and most of your upper GIs, that's typically don't eat anything 8 hours before the exam. Okay. For a small bowel follow through, possibly adding a laxative, possibly a longer duration of that NPO order. NPO means nothing, null per os, nothing by mouth. Okay. And then, of course, the examination of the large intestine via the barium enema requires a cleansing enema and a laxative and a controlled diet. So, depending upon how far down you're going and what portion of the GI system you're evaluating determines the extent of the prep. Okay, with the lowest portion, the large colon, being the most extensive prep. You're going to do all three of these for a barium enema prep. Okay. So getting our exam room ready. The room should be completely prepared before the patient arrives. We need towels and linens. We need emesis basins. The barium doesn't taste very nice. It tastes like chalk. The iodine doesn't taste very nice either. It tastes like medicine without the sugar. Okay. We're going to adjust the equipment controls to the correct settings. That means query the RIS, key up the correct patient, confirm that we've keyed up the correct patient, compare name and date of birth to the order. Okay. Set the footboards and make sure it's locked in place and it's not going to slip when you tip the table up. Change the operating system to enable the fluoroscopic source rather than the overhead tube. Okay. Check imaging devices and number of image receptors available. That's a little bit dated. If you are doing post-procedure overheads on CR plates or on a DR plate, make sure that that's readily available as soon as the radiologist is finished. And then prepare type and amount of contrast. That varies according to procedure. Right. In addition to the barium and setting up the control panel and the table, we're also going to want to make sure we find either the paddle or the spoon. The paddle is an inflatable balloon airbag on a stylus. It has a one-way valve and a little pumper ball, so it can be deflated or inflated. The radiologist usually likes this inflated and ready to go, and it's a radiolucent mashing device. Both of these are. Now the book calls this an F spoon. I guess if you turn it around, it's shaped like the letter F. I've only heard of it as the spoon. That's item B here, or image B. The spoon is just a hard version, a plastic mold version of the paddle. Some radiologists prefer the spoon, some radiologists prefer the inflatable paddle. The paddle does have an air bladder that can dry rot over time. And you can order a replacement air bladder for these things, and you can actually take out the old dry rotted one and refurbish and replace the air bladder. In these, I had to do that once during my career. It takes like 10 minutes, not that hard. You just got to get the hose to go down the stylus handle is all. So, but there's a little pipe clamp to attach the one-way valve and the pressurizing bulb. So both the paddle and the spoon are radiolucent, and they just allow for bowel compression to separate. In particular, we're trying to separate the small bowel loops and free them from superimposition so we can evaluate small bowel loops. So you wear these things out typically in the small bowel follow through. Okay. You probably won't need the paddle or the spoon for like an esophagram, but small bowel follow through, you're definitely going to need those. Okay. So in addition to those, contrast media should be prepared if it's an enema. Okay. Oh look, taste, enema, they shouldn't have put those together in parentheses. So describe contrast media and administration. Be very careful with your wording as you're talking to the patient, educating them about what they're going to go through. Okay. The enema tip placement is not a pleasant experience, and depending upon how you describe it, could raise the patient's anxiety a little bit. So just watch what you're doing with that. You should prepare the patient if they've never had barium before. Tell them it tastes like chalk. Okay. Tell them that the radiologist will be dimming the lights. That's so they can see the fluoroscopic screen, the display monitor, better with a darkened room. And then because sometimes it's not a radiologist, they say the fluoroscopist, sometimes it's a radiologist assistant rather than a radiologist. So just whoever's going to be running the fluoroscope, you should make an introduction as they enter the room, because the patient's been introduced to you, but they haven't been introduced to the radiologist yet. Now, exposure time. We're fighting peristalsis here with exposure time. We're also fighting breath motion, but that's more obvious to control. What's not obvious is the peristaltic motion, because that's an involuntary motion. So pathology, use of narcotic pain medicine, body position, respiration can all affect the speed of peristalsis. Okay, presence of pathogenic agents can affect peristaltic speed too. We can't control peristaltic speed. It is what it is. The only thing we can control is exposure time. And so typically your GI exposures are going to look better, have less motion artifacts if they're done with high KV, high MA, and then therefore low exposure time. Okay, so we want really rapid exposure times, almost instantaneous exposure times, so we don't give the opportunity for the peristalsis to actually move during the exposure. Okay. All right, so for the upright position, your exposure time is 1/10 of a second or less recommended. Okay. For the recumbent position, you can go slightly longer than that, but again, you want to keep the exposures as rapid as possible or as short a duration as possible, and that's going to reduce all types of motion. Okay. Deglutition arrests the respiration process. So for a swallowing picture for an esophagram, you don't have to worry about asking the patient to hold their breath, but you should have the patient hold their breath And then the radiologist knows these cues. If they take in a breath and swallow, the swallow peristalsis is going to be slower. If they blow all their breath out, barium in the lower esophagus is delayed at the end of full expiration, and that's because of the change in pressure between the abdomen and the thorax, and that's also one of the ways we trigger a reflux event is through what's called a Valsalva maneuver. So the radiologist plays with the breathing instructions sometimes to trigger certain pathologies like gastroesophageal reflux. Okay. Normal peristaltic activity, really you don't want longer than 0.2 seconds on average. If you have hypermotility, less than 1/10 of a second. If you go more than half a second, you're definitely going to see peristaltic motion. End of expiration is going to slow down peristaltic motion and also spread out the anatomy. So that's the best breathing instruction we can give for the post-procedure overheads. Blow all your breath out and hold it out, and that's going to slow down peristalsis. And then with a quick exposure time, we'll have less motion artifact on our images. Okay. Now, as far as post-procedure overheads go and or during the fluoroscopic procedure, because a lot of times the radiologists are taking digital versions of the overheads as they're doing the live fluoro. So you should still memorize the list of preferred projections, because then you can anticipate what the radiologist, what position the radiologist wants to put the patient in. And typically the radiologist will go through a set script of a particular order that they have been trained in. So as you're working with a radiologist, pay attention to his order of projections, and then you can better assist, and because you can anticipate what position he wants the patient in. And you can react a little quicker and assist. Your geriatric patients and your pediatric patients are going to need more assistance than your young adults and your middle-age patients. Okay, you should be able to shield for all esophagograms and all upper GIs. Small bowel follow-throughs and barium enemas, not so much. You won't be able to shield for those because it'll obstruct the areas of interest. Okay. Other ways you can protect instead of shielding is tight collimation. Okay, if you're doing an esophagus post-exposure overhead, you don't have to open to the entire chest cavity. Okay. I guess the exception to that rule would be if the radiologist wants a PHS projection post-aspiration to evaluate the extent of the aspiration, then you would not collimate to just the mediastinum. But if you're doing an esophagus oblique overhead, just collimate to the mediastinum 5 inches across from left to right with proper centering. Okay. The upper GI, you can collimate to the right, to the left upper quadrant in certain habitus, but remember the hyposthenic and asthenic habitus, you probably want to open up more because of the plunging stomach. So watch that. Shielding for esophagograms and upper GIs you should be able to shield without much restriction. And then use a good technique. Remember, you're introducing barium, so there's going to be more attenuation, more absorption, so less photons are going to hit the image receptor. So you should increase the penetration power of your beam and then slightly increase the number of photons you send as well, as compared to a conventional abdomen radiograph. So typically for your upper GIs and your esophagograms, you're going to go like 88 to 90 kV. For your barium enemas, you're going to go you're going to go, well, you might go 95 on your upper GIs if it's hypersthenic. Your barium minimas are going to start at 100 and go all the way up to 110 kV for hypersthenics. Okay. All right, so we got a review question here. Let's see. Peristalsis is affected by, is it body habitus, use of narcotic pain medicine, body position, or all of those? Is it 1 and 2, 1 and 3, 2 and 3, or 1, 2, and 3? And the correct answer is 1, 2, and 3. All three of those affect peristaltic speed. Okay. And so let's get into our essential projections here. You'll do a straight AP or a straight PA, depending upon what the patient can tolerate. And then you're going to do oblique projections, which are the really good projections as far as an esophagus go. In particular, the RAO projection and the LPO projection are going to show you an esophagus free of superimposition with the spine off to one side of the image and the heart shadow on the opposite side with the esophagus sandwiched in the middle. So those obliques are probably the best diagnostic quality of all in the Essential series. The oblique projections demonstrate the esophagus the best. Okay, so when we're doing an oblique esophagus, we can do an AP oblique or PA oblique. I believe this shows a PA oblique esophagus. And so the good angles to get the heart out of the way are the 35 to 40 degree RAO or 35 to 40 degree LPO, depending upon if the patient is prone or supine. Okay. Align IR and elevated side of the patient to a sagittal plane in the middle of the upper left quadrant. Okay. Center ray enters perpendicular to the midpoint of the IR, which should be at the level of about T7 again, because that's the middle of the thorax. Remember, the esophagus goes all the way up to C6 and then all the way down to about T11. So we want to, it's kind of like centering for maybe go up to T6 because you do want a little bit more superior real estate than you do inferior real estate. We don't need T12 on there, but we do need C6. So cheat up about an inch from T7. Okay, your straight AP or PA, it can be single or double. A double is typically done by the radiologist immediately after the patient swallows the fizzy crystals. So those fizzy crystals, they're made of sodium bicarbonate. As soon as that hits water, it precipitates carbon dioxide gas. So if the radiologist is running the fluoroscope and taking images just after the patient takes those crystals, excuse me for a second. All right, so typically your radiologist is going to open up either an esophagram or an upper GI with a swallowing series to watch the swallow reflex in the oral pharynx, but also to watch the barium pass through the esophagus, the cardiac sphincter to hopefully relax and allow the barium to drain into the stomach. Okay, so for your AP position, you do want to turn their head to the side because they need to drink and swallow in order to capture a barium-filled esophagus. Now, I've never done an AP esophagus with a patient supine that is laying on their back and then turn their head to the side to drink. Okay, the reason is that seems like it's prone for aspiration. I've only ever done oblique esophagus drinking films, and we can show you how those go. We are going to add a lab component this year to the GI lecture, so I'm going to show you how to pull off a drinking film. But with a patient prone, they might be better able to drink from a straw. So the instructions are drink and swallow. You don't have to tell them to hold their breath because remember, swallowing function automatically takes care of that, hopefully. So drink and swallow for a 4 count and then exposure. Centering, again, 1 inch superior, about T5, T6, because the esophagus, that's about the midpoint of the esophagus, starting at C7 going to T11, as we covered earlier in the anatomy section. Okay, collimate the field in side to side, and they say 12 by 17. You can probably go 5 inches across from left to right for most esophagus. Again, the exception to that would be if, in the case of aspiration, and the radiologist looking for that evidence of aspiration, you might need to open the collimation a bit. All right, so our oblique esophagus, again, this is a redundant slide. Yeah, I think we already covered this, but this is what it looks like. I think this is the RAO in this picture. The other one we had was the LPO. Okay, 2 inches lateral to the mid-sagittal plane. Should see the barium-filled esophagus sandwiched between the spine on, in the case of the RAO, the spine's going to be on the left side of the image, heart shadow is going to be on the right side of the image, and the spine and the esophagus is going to be sandwiched in between. We need drink and swallow for a 4 count to get a full esophagus. Right, for a lateral esophagus, just roll them into a lateral recumbent position. Arms forward, very much like you're shooting a T-spine. Mid-coronal plane, you don't have to go 1 inch posterior to the mid-coronal plane. The esophagus is on the mid-coronal plane. And again, center for T5, T6, which is about 1 inch superior to where you typically center at T7. Okay. Again, you can compress the collimated field from, this time, from front to back, anterior to posterior. You do not need the entire thoracic cavity, you just need the barium-filled esophagus. That is a poor attempt at raising the patient's arms. They could do better than that. That's why we're losing the proximal esophagus. And we can't see it as well. The patient should have raised their arms higher for this one. All right, so esophageal pathology, you're going to see this again in your senior year. Varices, those are little channels or rivulets in the distal esophagus caused by scar tissue. Zenker diverticulum, that's in the proximal esophagus. Those are diverticulum forming off the oropharynx, that is false channels or false pockets. Schatzki's ring is a mucosal ring in the distal esophagus. It's where scar tissue has arrested the muscular layer and caused it to seize up and have a fixed diameter. A hiatal hernia is best demonstrated with Valsalva maneuver. A hiatal hernia is where a portion of the stomach has herniated into the thoracic cavity, and so the esophagus is not penetrating through the diaphragm anymore. The stomach has come up and herniated through the diaphragm. Hiatal hernia is the #1 root cause of gastroesophageal reflux disease. And then Barrett's esophagus is peptic ulcer with stricture at the distal esophagus. Barrett's esophagus is a sign of severe esophageal erosion as a result of gastric esophageal reflux disease. Okay. There's a demonstration of Schatzki's ring, radiographically. You'll see a lot of the other pathologies in your pathology class as it comes around your senior year. All right. So performing an upper GI series, you're going to do a scout film. You don't necessarily do a scout film for an esophagus. You can do a scout film. Some radiologists do call for it. Sometimes it's a soft tissue neck. Sometimes it's a KUB. Sometimes it's both a soft tissue neck and a KUB. For a GI series, it's a KUB. Okay, so shoot a KUB on the patient before you introduce barium. The scout image serves two purposes. It gives the radiologist a comparison view after contrast has been administered, and it confirms that the preparation was successful. Okay. All right. All right, guys, getting back to it. We want the stomach to be empty for the upper GI, obviously. Any residue or residual food boluses could cause a, it causes indeterminate diagnostic finding is what it actually causes. Residual food can create a filling defect for the contrast. And so that filling defect could look like an ulcer or could look like a mass. And so you get a non-diagnostic study with residual stomach contents. And this also carries through to the small intestine and large intestine. Any residual matter inside the gastrointestinal tract will produce a false positive that can't be ruled out as a pathology. And so we really like the preparation to be complete for a stomach upper GI series. You don't have the patient eat or drink anything for 8 to 9 hours before the examination. Okay. If it's an upper GI with small bowel follow through, we extend that to dinner time the day before. Okay, so usually it's like NPO after midnight is the order, or something similar to that. But for a small intestine, we need to go a little bit longer, so it's NPO for 12 hours or the evening meal rather than midnight. So nicotine and just regular old chewing gum can stimulate gastric secretions, and so that affects peristalsis, that affects the ability, if you have more gastric secretions, it also affects the barium's ability to adhere to the intermucosal lining. And so nicotine and smoking and gum chewing are also not, you can't do that as a patient on the morning of the exam. They affect the outcome of the exam. So no cigarette smoking, no gum chewing on the morning of the exam. So NPO means NPO. Right. Single and double contrast upper GI. So we're going to use a combination of barium sulfate, typically in a liquid form, but also different thicknesses of that liquid. We're going to have a thin barium and a thick barium. We're also going to have carbon dioxide crystals, or seltzer water sometimes is used, but the carbon dioxide crystals, the sodium bicarbonate is preferred because the seltzer water adds water volume to the stomach and that dilutes the barium. Okay. Additionally, occasionally for swallowing dysfunction as a diagnosis, you're going to use an easy disc tablet to see if it passes the esophagus and the cardiac antrum. Sometimes a large pill will get hung up in the cardiac antrum, and so the easy disc barium pill is 1/2 inch in diameter. Okay, that is a registered question. The standardized barium pill is 1/2 inch in diameter. All right, so a biphasic examination is just another way of saying double contrast. And the double contrast is air and barium typically. Okay. Your essential stomach series, if you were a tech in my era of being a technologist about 15 years ago, you would do post-procedure overheads, and you would always do this series of projections after the radiologist was done doing their spots and their live fluoro examination. Okay, you'll do a PA oblique LPO, an AP oblique RAO, a right lateral, and an AP. Okay, and you can do them in any order. I usually started out with an AP, an AP oblique, and then rolled to a lateral, and then finished up with the PA oblique and the PA projections. So that way the patient is continuously rolling from their back onto their stomach. Okay. The different projections will show off different parts of the stomach and duodenum. All right, so the first one for the PA stomach, the patient is recumbent prone or they are upright. Align the midline of the grid, that is the image receptor, to a sagittal plane passing halfway between the vertebral column and the left lateral border. Basically center on the left upper quadrant. Superiorly to inferiorly, you're going to center longitudinally 1 to 2 inches above the lower rib margin. Again, right in the middle of the left upper quadrant. Okay. If you do an upright, remember that the stomach is going to sag just a little bit more, so drop your center somewhere between 3 and 6 inches for an upright PA stomach, because all the soft tissue contents are pulled down by gravity. Okay. So here's your PA stomach. You can tell it's a PA stomach. First of all, the spine looks like an AP or PA presentation. There's your angry emu. And so you know it's not oblique because of the way the spine looks. And then you see air in the fundus and barium in the pylorus. And if you pay attention to the anatomy of the stomach, the fundus is actually in your left armpit. So it's on the mid-coronal plane on the left side underneath your diaphragm. Whereas the pylorus is, for normal habitus anyway, the pylorus crosses the midline anteriorly, like right underneath the transverse colon. Okay. So since the anterior portion of the patient is got the barium bolus, and the more posterior section, the fundus, has got the air bubble. Can you see the air bubble on this? It's kind of dark, but you can see an air bubble there. That means the patient was laying with their anterior abdominal wall closest to the floor when this radiograph was taken. Now, if you do an upright one, you're going to get a meniscus line, an air fluid boundary, nice horizontal line sign, and that would be the difference between an upright and this one is done prone because there is no air fluid horizontal line here. Okay. For the PA oblique stomach, the patient's in an RAO position that rolls the heart shadow off to the left, but it also rolls the entire stomach to the left of the spine. So we're more concerned with the spine overlying the pyloric antrum. Okay, and the superimposition of the spine on the pyloric antrum. So the RAO position rolls the pylorus to the left of the spine. The spine rolls off to the right. Okay, again, where are we centering? We're centering to the middle of the left upper quadrant. How much are you going to turn them? Well, it depends on their habitus. 40 to 70 degrees of rotation. And it's actually less rotation for the hypersthenic patients than it is the asthenic patients. You need 70 degrees of rotation for the asthenic patients. And then this is what the RAO looks like. Again, very similar to the PA. The air bubbles in the fundus. The barium bolus is in the pylorus. The pylorus is free of superimposition of the spine. But now we can also see the cardiac antrum facing toward the X-ray camera. So you can see the rugae kind of form like a starburst pattern right there. That is the opening to the esophagus faces, and it's a nice air contrast. If you're using a double contrast study, it's a nice air contrast view of the cardiac antrum on end. Okay. For doing the LPO position, obviously you're going to flip the patient to a more supine posture and then roll them onto their left side. Again, 30 to 60 degrees, it's a range, but 45 degrees is for average habitus. You roll them less again for the hypersthenic habitus. Roll them more for the asthenic habitus. Okay, and again we're going to center for the middle of, it says midpoint between xiphoid and lower rib margin. That's roughly the same thing. It's middle of the left upper quadrant is what we're looking for. Okay, so here's our LPO. It looks very similar to the RAO as far as how the anatomy presents. The only difference is the barium has swapped places with the air. And so now we see an air contrast pylorus and pyloric antrum. Okay, and I think they have that mislabeled. That is not the pylorus, that's the duodenal bulb that they have labeled as the pylorus. So slight error in the text here. You can tell it's the duodenal bulb because the pyloric sphincter is actually immediately to the left of that area they're indicating. Okay. For our lateral stomach, we want to lay the patient on the right side. It doesn't indicate that here, but the right lateral of the stomach is actually preferable. If you do a left lateral stomach, then you're going to see barium everywhere. But in a right lateral stomach, the barium goes to the pylorus, and the upper 2/3 of the stomach is in air contrast. So you can see the mucosal folds displayed very nicely, and you can see the difference between the anterior mucosal wall and the posterior mucosal wall on the right lateral projection. Okay, and this is how it looks. So patient's right side down, and that means the barium is all going to flow into the pylorus and duodenum. All right, so again, yeah, lay them on the right side. The barium funnels into the pylorus, dumps into the small bowel. The features that you can see, of course, you can see the anterior rugae and the posterior rugae lining of the stomach for the upper 2/3 of the stomach. But you can also see the duodenum C-loop in profile, basically free of superimposition. A little superimposition with the spine there posteriorly, but typically the duodenum tucks behind the pylorus, and it's very difficult to see it without being superimposed by the pylorus. The right lateral of the stomach gives you an unimpeded view of the duodenum. Okay. All right, for the AP projection, pretty straightforward. Lay them on their back, AP supine. Center for the middle of the left upper quadrant, and that the centering point changes depending upon whether you're using a 10x12 cassette, you better not miss, or a 14x17 cassette, which is probably the 14x17 cassette is probably preferred. You're just asking for, you can fit a stomach on a 10x12, but it's really, really close. You have to be exact with your centering. 14x17 cassette gives you a little bit more freedom to be off center and still not clip any of the demonstrated anatomy. So just be mindful of that. I recommend overheads being done on, if you're even doing them, on a 14x17 inch field, vertical. All right, so here's what our AP stomach and duodenum look like, and this is the image critique portion. So how can we tell this is AP? First of all, the gas bubbles in the pylorus. So that means the patient's laying on their back, because we know air bubbles rise to the highest position. They seek out the high ground in a gravitational field. So if the patient's laying on their back on a table, the pylorus is actually the furthest point. So again, air bubbles are seeking out the high ground. The pylorus is furthest from the floor because it's anterior at the midline. The fundus part of the stomach is closest to the floor with the patient laying on their back on the exam table because the fundus is in the left armpit or left axillary region. So the fundus is filled with barium. That's not a surprise. The pylorus, pyloric antrum, and the duodenal bulb filled with the air bubble. And this is one of the ways you can tell it's an AP. Now, how do we know it's not an oblique? Well, we can see the angry emu. We can see spinous process is centered on vertebral bodies. And so we know the spine is not oblique, therefore the patient's not oblique. Okay, so we use the spine and the rib cage partially, and if the pelvis is on there, the pelvis to determine whether it's an oblique or whether it's a straight AP. All right, notice the barium hasn't tracked through the small bowel. This is very early in the examination. Now it does say that, remember the positioning said center for the right upper quadrant, or left upper quadrant rather. This is centered for a conventional KUB, so I don't understand why they use this as a representative example. It's not centered for the left upper quadrant. Right, that's the end of, I don't know if I put that in the right, yeah, I did put that in the right place because we went through the entire stomach. So that's the end of part 1. This is the last slide, but this is not the last of the chapter. We're going to continue with this with part 2 in a separate recording. So thank you.